And now I call for the presentation of Professor Dr. Kamal Ibrahim, the clinical professor of orthopedics in Loyola University, Chicago, and the past president Scoliosis Research Society. And he's going to give us a lecture about an overview of the scoliosis. Thank you, Dr. Hisham.
Thank you very much. Good morning, everybody. Sabah al-khair. I see many of my friends here. It's good to be between you. This year will be 45 years since I graduated from the same university. Quite a few changes. When I came and looked around, the only two things still are the lecture halls and the main entrance back behind that. It's very nostalgic for me. Thank you very much for the invitation. Professor Atif Hanna Azamni, and thank you very much, I appreciate it. And I'm going to change the tone a little bit. We'll go on to talk about scoliosis. And I'm originally a pediatric orthopedic surgeon who drifted, and I did enough in pediatric. I built my name on Kevas feet and pediatric surgery. Then with time, I drifted into scoliosis. So it was nice to hear about the slip again and learn something. And I'm sure by end of tomorrow, that will be a great course. I saw the program and very impressive. Much appreciated. I understand that we have resident, we have young surgeons, surgeon in training, and expert and professors. So try to cover all that in one talk will be challenging, but I will start with the basics. So please, professors, bear with me. I know this course is mainly for resident and young surgeons. I'll start with the basics, then we'll advance to very advanced, who really will be directed to the scoliosis surgeon who are here, if any. Sorry. Okay. Yeah, that's fine. Sure. That's fine. It's. If I stand and bending to my side, that's not scoliosis. That's just position. So the two principles for scoliosis is, I would assume this, is curve and the rotation. And if you don't have rotation, you don't have scoliosis. And the hump is a result of the rotation. So the deformity is a curve and rotation of the vertebral body in the horizontal plane. And that would be scoliosis. Otherwise, it would be just position. Kyphosis lordosis, that's excuse me, sagittal alignment deformity. Thoracic kyphosis, lumbar lordosis. And now we, over last 10 years or 15 years, we looked more into the global alignment all the way to the femoral head. And we try to create relation between the pelvis and the alignment of scoliosis, of the alignment of the sagittal alignment of the kyphosis and lordosis. And we'll talk about that later. But that tells us when you're dealing with spine deformity, you need to have X-rays, including the neck, including the hips, in the AP view and the lateral view. Because the pelvis, as the French say, the pelvic is, is called the pelvic vertebra. The pelvis is part of the vertebral body of the entire spine. And you have to take the establishment position in your plan. Otherwise, that's why you see people had treatment and leaning forward because sagittal alignment was not taken in the proper consideration. So we will go through the different type of scoliosis. Very quickly, I will cover congenital scoliosis and others. Then we'll go to the big part, which is 80% of all scoliosis is adolescent idiopathic scoliosis. And you know that the congenital happens because either the vertebra did not separate from each other partially, and that's lack of separation, lack of segmentation, or vertebra did not form partially, that would be lack of formation. And I'll show you examples soon. Then neuromuscular scoliosis, this is imbalance, result of the paralytic condition. You can have the list here and you can add to it maybe in Egypt still the older generation, late teenager, young people still have a polio. But polio also part of the paralytic scoliosis, and the scoliosis here is a result of the imbalance. And I'm going to talk about it because the goal of the treatment is completely different from treating idiopathic or congenital. And then you have the syndromic scoliosis, which now we are, over the last many years, dealing with growing rods, trying to control the scoliosis in 2-3 years old child to allow the body to grow and progress with the growth by lengthening the bone, lengthening the rods. And recently there is a magnetic system trying to lengthen the system inside the body without opening it. That's a complete different specialty, early onset scoliosis. And if the time allows, at the end I can give you some talk about it. If not, you can find enough about it. But properly, for general orthopedic surgeon, pediatric orthopedic surgeon, it's just adequate to know there's a lot of things for early onset scoliosis. Finally, we're going to talk about the idiopathic scoliosis, and that is the 80% of all cases. So really in your practice, when you go out and practice, you will find this is the majority. What you see is the adolescents with scoliosis. So for congenital, you have either lack of formation, hemivertebra, or lack of segmentation. You see the pedicles here, you see bar here. There is no formation, there is no separation at all. And that, as a result, in this case, if it is growing, we excise this part and we align the spine properly. This one we know is going to progress. There is nothing, those are growing, those are not growing. So that we intervene early to correct it. And that's what we do for lack of formation. We excise the vertebra completely, and that's used to be done many years ago by opening the front, opening the back. Many years ago means 20 years ago. I'm one of the people present paper in 2004 doing all of it from the back. We open from the back, you go around the vertebral body, you all the way to the front, you do retractors, and you excise the vertebral body completely, and then you can just do fixation. That decreased surgery from being 2 procedures to 1 procedure. Lack of segmentation, as you can see, the pedicle here is clear. As you can see in this X-rays, the bar is here, the pedicle is here. This is no solution except you fuse this part. You cannot wait on this one because we know it's going to progress. So there is no advantage at all of waiting to see what will happen. And fusing 3 vertebrae is not going to affect the growth of 2 or 3 years old child. But if you leave it and you have a 90-degree curve, you are really in trouble. So we'd go that early. And of course, the natural history is very clear. If you leave that, that's what you end up, almost like 180-degree curve, scoliosis with kyphosis. The neuromuscular scoliosis, that's cerebral palsy, polio, muscular dystrophy, etc. The aim here is different. The aim here is to make the pelvis horizontal. This patient have paralytic scoliosis. She is sitting on the right ischial tuberosity. Her pelvis is up there. Her ribs almost in her pelvis. And that is collapsible scoliosis, does not stop. It's a paralytic, it is imbalanced, it will continue to progress without, during whole life. So our aim, we don't care how much I correct. It's not like idiopathic, oh, I brought the curve from 70 to 20 or 10. Here I don't care about the number. My interest here is to have the head centered over the pelvis. The pelvis is horizontal on the seat. Whatever happened between this is a design you do to maintain the head centered over the pelvis, the ribs centered, or the cage, thoracic cage is centered over the horizontal pelvis, the child sitting on both sides. And the aim here is to avoid sores between the ribs and pelvis, and this is reasonably average case. We have seen cases where the head almost here. The pelvis is oblique, has to bring it back, and the head will be centered over the pelvis. The question comes, why we're doing this? Unfortunately, with the modern medicine, these kids don't die early. They chest taken care of very well, pneumonia treated, problem taken care of, gastric tube, they get them nutrition. They can live to 50, 60 years old. And then they will be in very bad shape from seating, nursing, taking care of them if you don't treat the scoliosis. So it is not just exercise in appearance. It is really caring for the child and nursing of the child. And that's what we did for this patient. We fused her from T2 to pelvis, to ilium bone, and you can see the pelvic obliquity here, and you can see the pelvis horizontal here. We create proper kyphosis, proper lordosis, so the seating, the head, centered over the pelvis in both lateral and AP view. And the whole idea is, regardless what kind of curve you have, I have the head centered over the pelvis. That was a quick review of a whole course about congenital and idiopathic scoliosis. Now we're going to talk about, congenital and neuromuscular scoliosis. Now we're going to talk about idiopathic scoliosis, which 80% of the cases, which you will see all the time. We divide them into early onset scoliosis, as I mentioned early, and those are different group, and juvenile between 5 to 10, and adolescent, which is the most common. And really, when you look at it, scoliosis progresses with the growth spurt. And we have two growth spurts, one before age 5, and the second one, adolescent growth spurt. So that's the best way to look at them. We squeeze juvenile here because the problem with juvenile, it is true idiopathic scoliosis, but they have a long way from maturity. That means you have a long way for the curve to progress. They behave differently. Majority of them may progress to surgery. So, battery is done. So that's why we created a special group, although they are true idiopathic, they are not early onset. They are not early onset, but because the time to maturity is very long, the higher instance of progression to surgical case. The idiopathic adolescent is the most common. It's very important, it's pain-free. And this is important for the junior surgeon here, because I get referral very often from orthopedic surgeons, a kid with 15-degree curve and back pain, and is told the back pain from scoliosis. Scoliosis is pain-free disease. You will not get back pain before 70, 80-degree curve, because mechanical back pain. So don't confuse that with other issues. The child may have other reason to have back pain, and don't confuse it by thinking it's scoliosis. Scoliosis is pain-free disease. The curve develop during period of rapid growth, and the child otherwise healthy. This is one of the major issues you face if you're a scoliosis surgeon. Try to convince a family that the child needs treatment with a child that doesn't have anything in their eyes except crooked back. And they have to go through the natural history to understand what really we're doing for this child, why we have to treat. And the important thing is two principles, which make sense, so I'm going to talk about soon. The growth, the evaluation of the curve depend about significance of the curve and the remaining period of maturity. It's just logic. All our decisions based on the two principles. How far this child from the maturity, and what the significance of the curve. What is, or how significant is the curve? And that's really the basic of discussion of natural history of scoliosis. So what we're going to cover in this discussion in the remaining time is I'm going to review the natural history. I'm going to discuss management options. I will discuss surgical decision making for people who are interested in surgery of scoliosis. And that means what do we do in surgery, why we do surgery, what we do in surgery. Then I'll show some case discussion. Natural history of scoliosis, again, the two principles. Degree of the curve, maturity of the child. And you can see here that are the two we're going to discuss. Bill Bannell, who was my teacher a long time ago, did a good study in the late 70s and reported in the 80s, correlating children immature. So let's define what is immature. Immature is a child who did not show any signs of adolescence development. No secondary sexual character, young child, and you will ask me what that means, word mature. We're coming to that, a long discussion about it. I'll cover it very soon. But in that immature child, if the curve is small, chance of progression is small. Curve is big, chance of progression is big. Probably this slide, one of the most important slides, because when you have a chance of progression 20%, you watch the child. When you have a progression 60%, you do something. Bracing, we'll talk about later. When the curve very significant, we're going to progress, you fix it, surgery. This is just to keep the number loss in your head. Then all the discussion coming up, it will be covered under those numbers. So all of you know about razor sign. Razor sign is the capping of the iliac crest. So razor 1, just beginning of the capping, just to start to happen. Razor 4, complete capping. Razor 5 is fused. Razor 5 is not important at all because it can happen as late as 20, 21, or 18 years old. Maturity of the spine is completely done by razor 4 when you have it all the way covered. So that's what we need to know. Razor 1, 2, 3, 4. It's a very important thing to know. Maturity or immature child has to be before razor 1. So you go back to last slide. What is the definition of mature child? The child who does not have razor sign at all. Then a question comes, what that means. 3 years before razor sign, 1 year before razor sign, I don't know, I have only razor sign. As a result, we had to develop other methods to evaluate the degree of maturity, and we'll go through that soon. Second paper, which really is still landmark, is Lowenstein paper, and he showed that immaturity, razor 0, and actually this time, this paper was early in 80s, we did not know that razor, it happens, razor 0 is the immaturity, razor 1 is the beginning of maturity. So he lumped those together, and again, we come to the same numbers. If you are small curve, below 20, 20% progression. You go above 25, and up to 30s, you go up to 70% progression. But this is immature child. Again, the same as Bill Bannell paper. Now you go to maturity, razor 2 to 3 to 4, numbers completely different. So if you see patient in razor 3 here, and the curve is 20, you can tell the patient don't come again. You see the patient at razor 3 with 30-degree curve, you watch the child. But here is different from here. You are not going to treat him. So the question comes back, how can I find my child here? This is a million-dollar question for last 20 years, 30 years, and subsequently other way of defining maturity developed. Now we know from the work of Saunders and Demenglio and others, the growth pattern is they grow, height velocity, they're growing fast, they reach the peak, and they slow growth. And you can see now, we know when try correlate all this information with razor sign and menarche, we found that razor 1 really beyond the peak. That's why we know we need to get the child in immature stage either here or just before here, so we can protect the child during that peak, which is the worst time for progression. They grow fast, they reach the peak, they go slow. You need to get them here to brace them, or here to stop progression. Even menarche, which we ask the child all the time, still menarche is around razor 1. Tri-radiate cartilage closes at the down slope. Razor 2 is here. So if you look at this curve, correlate to the 2 slides that show you, smaller the curve, younger the child, bigger the curve, younger the child, the chance of progression, and after maturity, regardless of kind of curve, progression is very slow. Then we come back, okay, we know the science, we know the curve. How can I find the child at the peak or before the peak? We look at Tanner classification. Tanner is a British pediatrician in the early 60s, divided the adolescent maturity into 5 stages. And the 5 stages correlating to the height, and the height is important for us because the velocity, the peak velocity of the height is a bad time for scoliosis progression. So we look at the curve here. This is the growth pattern, and that is the peak of the growth velocity. And the down slope is a slow time for growth. He correlates all that with the breast development. Look here as menarche. Where's menarche here? I can see. Okay. Yeah, menses, sure. Look at menarche and follow this line. You find it here, as we just showed you. So you cannot wait for menarche to make a decision. You're already beyond the peak. So now we look at the breast development, axial hair, pubic hair. You don't have to embarrass the child, but you can look at the child generally. And when you exercise your brain to use Tanner classification, very quick look as a child walking in your office, you know right away she's here or she's here. So it's easy to keep that graph in your head all the time, and just by one look with experience, you can know, this Tanner 1, this Tanner 2, no, she is Tanner 5, which is mature, and so on. This helps us a lot, because now I can not depend on razor sign, which we hear as we said, but I depend on other stuff to tell me where I'm here. This is very important. For the boys, the same, but the growth velocity of the boys, a little bit the curve is different. They grow fast, and they have a long time for complete maturation. It's about 3 years. But again, we have the testicle size, the penis size, the pubic hair, the axillary hair, the facial hair. And again, when you have that experience, you don't have to embarrass the child. Just look at them. He has nothing in his face. Left his arm is nothing there. He's Tanner 2. And then you can go from there. So there is another way to look at the peak of growth velocity. If you have a pediatrician following the child for a period of growth, and I know that pediatrician every visit they measure the height, you put in the curve. Or if you're following the child since he's child very early and watching the growth every visit, you come to you. At any given year, if the child grew 10 centimeters, 4 inches, 5 inches, you know he went with the peak. This helps for me because it's easy for me to get the growth pattern from the pediatrician, and I can look at it. From last April to this April, he grew only 3 centimeters. Then it's not in the peak. But from this April to next April, he grew 10 centimeters. Then I lost it. I'm beyond the peak. And so that another way, probably if you have a follow-up on the child without looking at other classification, you can figure quickly, are you before the peak or are you after the peak? The Saunders modified the evaluation of the growth plate of the epiphysis in the fingers. And they divided into 5 stages. Now there is about 10 stages. But for you, you can go and look at the paper. But for you, very quick evaluation. We look at the pattern of the epiphysis. If the epiphysis is small and below, less than the boundaries of the metaphysis, that is immature. And you start growing in the width till you reach the level of start cupping around the metaphysis, like here, that you know you're already beyond the peak. Of course, it's not that simple. If you look at the paper, you can classify it very well. And you correlate that to the peak here, you know where you are. It's a little bit time consuming, but to get used to it, you can do it very quickly. And divide it further by the year later, Saunders, that's 08, tried to simplify it from instead of looking at 10 fingers, try to do it in one hand, but the same idea. You're looking at the cupping of the epiphysis in relation to metaphysis. If the cupping start to happen, you're already beyond the peak. So why we are treating these kids? Because we know natural history. This is very old paper from Nicholson in the 70s, and it's criticized a lot, although still quoted all the time, because it was a Humpty Dumpty collection of patients with scoliosis, neuromuscular and mainly congenital, skeletal diseases, and idiopathic. Because the idiopathic is the majority, the paper is taken as valuable because the majority of the patients were idiopathic, and really give it a very gloomy picture for the patient who are not treated for scoliosis. But the best 2 papers really about natural history are the one came from Iowa in 83 and then revised, followed up the same patients to 2013. So they have a follow-up of about more than 50 years, natural history for patients who are not treated. Few things came out of this paper of value. Curves below 40 will not progress after maturity. Curves above 50 will progress after maturity definitely, between a rate of 1 to 2, sometimes 3 degrees per year. Although it sounds very small, add 10 years for 16 years old child, then you end up by already 20 degree for the 50, now we have 70 degree bad curve at 30 years old, young, the peak of the health and time and productivity of the person. So this was very valuable for us. Second, thoracic curve progressed more than lumbar curve. Lumbar curve give you more back pain than thoracic curve. And it's very important it doesn't show the doom and gloom Nicholson paper showed. The only, I shouldn't say the only, the important complication for untreated major curve is back pain and decrease daily living function. But they still live normal life till you go up to 120 degree curve. They die from pulmonary. So this was little picture, better picture for long term, but also tells us if you have a child of 50 degree curve at age 15, probably do surgery now, then waiting till age 30 when he comes back with 75 degree curve. So give us some idea of prognostic value for the child who's healthy but just has a curve of 50 degree, what to expect 20, 30 years down the line, and you can give, today you can give the right, appropriate advice. So the conclusion of natural history. all what we heard. The larger the curve, the younger the child or the patient, the higher is the risk of progression. Very logical. Significant progression would occur during the peak of growth spurt. Another logical thing. And we decided how we decide about growth spurt and the peak and so on. Adults' progression is occurring about 50, and that's why you should be taken care of account when you look at the patient. The question comes out, what about 40 to 50? Is the gray zone. Below 40, they don't progress. Above 50, progress. 40 to 50 is the gray zone, and those patients, I follow them for 5 years after maturity. If they show progression, they will know that they're going to go to the 50 group. You can diffuse them. If you have 5 years and no change, you discharge them. So, management of idiopathic scoliosis is logics. Either you watch, you brace, or you do surgery. And we're going to talk about PT too. Observation. Now, you know the natural history. Let me give you a test. You have a child who is 10 years old, Tanner 0, and the curve is 15 degrees. Who will put this patient in brace? Ten years old, Tanner 0, young kid, 15 degrees curve. Right thoracic, 15 degrees. Observe. Exactly. Thank you. So if somebody awake in the morning, good. We are going to observe the child because the chance of progression, what? 23%, according to Benel. 22% according to Lowenstein. So why put 80 people in brace because I'm worried about 20? Of course, that's not right. So those will observe. So this is the observation group. The patient who is prematurity and very small curve. There is one more trick. What about the curves? Yeah, that's just to cover it. The patient here and a small curve you watch. Okay. Let me ask a question. I think you can figure it out from there. But imagine now the patient is menarche. Just start last week. That means she is Tanner 3. She is beyond the peak. And she has 38-degree curve. What I do? Observe. Exactly right. Patient beyond menarche, beyond the peak, and 38 degree, yes, high curve. But she may not change. If progresses, I will put her in brace. The chance to progress is how much? 23%. So we'll watch for that. So those are the two cases for observation. Very young and small curve, or very advanced with high curve, but you may not change. The controversial, which you will hear about all the time, the physical therapy, I can take your back and manipulate you and make you straight, and all the good stuff has no value whatsoever. And you'll practice that all the time. In the state we see it. I'm sure you see it here more from the physiatrist, rehab physicians, from the physical therapist, etc. And chiropractor, I know they have started a chiropractor in Egypt. That doesn't mean very much because enough studies done and there is no scientific proof whatsoever for anything of the stuff. Electric stimulation, we tried that in '82. I was in the FDA group for studying, and after 3 years, after very enthusiastic beginning, curve goes straight right away. After 3 years, you start seeing curve progression, and by maturity, the curve back to natural history and goes more than when you start from. So that was eliminated. Okay, the new thing now, Schross therapy. Schross was a physical therapist in the 20s, and she had scoliosis herself in Germany. So she designed exercise program for herself, and apparently she was able to control the progression of scoliosis in herself, so she developed that treatment. Never been documented. It's going on for 90 years now. Many times people looked at it, and actually there are few patients in Egypt went to Stross treatment. I did surgery, a couple of them in Chicago. After the Stross failed, they came to me. But the typical German publicity in Middle East, that they went there for Stross therapy 3 months a year, they sit there, inpatient, etc., etc. Recently, over the last 15 years, 2 centers, Milano and Barcelona, took Stross treatment and found there's some basic science there, but need documentation, need hard work. And they presented their data. And the idea is of Stross treatment with the modification of Milano and Barcelona is you try to exercise the muscles which control the correction of scoliosis, the breathing muscle, intercostal, paraspinal, large back muscles, isolating every muscle, exercise that muscle. So you can see in the picture here, progressing from scoliosis to straight back by exercising the muscle. Then repeating and repeating and repeating and repeating for continuously 8 hours a day for 3 months, hoping the brain will be re-educated to walk always with a straight back, not with scoliosis. Makes sense? Did not prevent progression. They don't have a good data, although we are paying money now, SRA is paying money to do a good study about it. But they showed anecdotal data showing that it can control the scoliosis. When I went to visit Dr. Rigo in Barcelona, he's on here, he's a smart guy. He does exercises with bracing. So really enhancing the value of bracing. We know bracing result failure is about 30%. He claimed that he changed that to 20%. Fine, 10% extra success rate for bracing with exercises. Great, we take that. But don't believe anybody will tell you Stross method will correct scoliosis completely and will be completely straight for life. In this case, we'll take them and do surgery because it doesn't happen. So this is the whole idea, is trying to teach them how to maintain their back straight with the brace. Bracing, we have to understand basic principle for I have another time. Huh? What time when I finish?
10 minutes.
10 minutes from now. Oh, we're doing fine. Because that's important. You don't need to hear about screws. We put screws in the spine. That's, if you come to do scoliosis, we can teach you that. But you need to hear about basic science, natural history and basic information about scoliosis, because that's what you will see when you go out to practice. Basic principle for bracing is not to think brace will correct. Successful brace is to control the curve so it does not progress. During bracing time, you will see the curve decreases, which is important. But when you finish bracing time and you stop the brace, the curve will creep up to where we start from, within 5 degrees. This is successful brace treatment. If it goes above 5 degrees, they failed the treatment. And we watch them for a couple of years after bracing. So the point is, because if the brace was going to correct the scoliosis, we could have braced everybody with curves to bring back straight. That's not the case. Brace controls scoliosis till maturity. And successful brace is the scoliosis does not progress beyond that. So if we know this, then we look at the cases of progression, expected progression. We know that curve between 25 and 40 in immature patient, growing child, here or at here, will progress. As we said, 68 to 70% in the natural history. Those will brace them to stop it from progression. And when the patient reach here, a reserve 4, we stop the brace. And the curve will go back where we start from, and I watch him for 2 years, and he's fine. That successful treatment, 70%, or will progress inside the brace, or will progress after brace. Those failure treatments, 30%, and they end up with surgery. Braces are different kind. Every city in the world has a brace for its name. All of you know Milwaukee brace, total body brace, etc. I prefer this brace. It's called Rosenberger because the body is not trapped in the plastic. Don't deform the ribs. The plastic is loose, and we use the pad opposite the curve, and the same basic principle orthopedics. When you want to correct something crooked, you make it straight by 3-point fixation. That's exactly what we do. 1-point fixation here, 1-point pad here, this part of the plastic, and then this pad is opposite the apex of the curve. This is the right thoracic curve, the common one. So the plastic is loose, but the pads doing my 3-point fixation, they are not pushing the ribs to deform them, and very comfortable for them. This is Rosenberger brace that I use. Montreal came up with the brace spine core. That's about 20 years ago. And it's a very smart idea. You digitalize the spine, you digitalize the x-rays, you put them in a computer, and the computer tells you how many straps you put on the body, where you put the pads for them to correct. That has to be checked every week, re-digitalized every month. Unfortunately, because the exhaustion of the work with the patient did not succeed in North America, and I'm aware only about one place still using it's Montreal. So just mentioned because some people they go on the internet and read about brace with the straps. At least in the US, they come to us and I like the strap brace, I don't like the plastic brace. And I go through the whole story, and the failure rate was very high, not because the brace is bad, because applying the brace did not succeed outside Montreal. So bracing, very important, also bracing time and bracing results. We use the brace 16 hours because we did a paper a few years ago with a transducer in the brace to tell us about compliance. And the patient who tells you she wears the brace 23 hours, she ends up by probably 12 hours from the transducer. So trying to help the compliance of the patient, a study was done in the 80s and showed that 16 hours is as good as 23. So we ordered them for 16 hours a day. And the most important paper came out, a landmark paper, very well studied, very well controlled, and showed that always a controversial, does brace work or doesn't? No, it does. And Stuart Weinstein showed that, and this published in New England Journal of Medicine, is a very respected paper. It does change natural history. Success rate 70%. And number two, it is dose related. They showed 16 hours and above is as effective as 23 generally. Below 12 hours has no effect whatsoever. So I give this paper to my patients so they understand. If you're going to cheat and fool me, don't go below 12 hours. So we come to surgery, which now I have the 5 minutes only to cover the surgery because really you don't need to hear about the surgery very much. But it is clear that curves above 40 degrees in growing a child. So now it doesn't apply the 50 we talked about. Still growing child, the brace doesn't work, you do surgery. But the patient progress above 45 and post-menarche, then we know it's going to progress for good, then you do surgery. Or curve of 50, natural history tells you that is going to progress, then you do surgery. So here, 45 you watch to here. Here, 50 you do surgery. Here, 40 to 45 you do surgery. And that's applying to the natural history. And the goal of surgery is to correct everything. The only thing you can do with surgery is to correct everything. You need curve correction. You need level shoulder off here, shoulder leveled. You need coronal balance, the head over the pelvis. They're not shifting right or left. You need hump improvement. You look at this patient after surgery, there is no hump. You need sagittal balance. And sagittal balance is related to the pelvis, good kyphosis, good lordosis. This is the aim of surgery when you come to do decision. And you have two questions when you go for surgery. Am I fusing one curve? If I have a patient with one curve, that's easy. If I have a patient with two curves, do I fuse one curve or two curves? And that comes with a word called selective fusion. This patient has right thoracic, left lumbar. Should I do the right thoracic only and left lumbar will correct by itself because selective fusion, or should I do both? Right, high thoracic and lower thoracic, the same question. Shoulder is very high, then I have to take this curve in account to bring the shoulder down. And after that, after I made the decision, I'm going to do one or two curves, I make second decision, where I start, where I finish, and what to put in between. Lenke classification came to sort out this old dilemma by classifying scoliosis into 6 groups and saying that if you are in 6 groups and you have a significant one curve and non-structure second curve, you fuse only the structure curve. So the question comes, how we define structure and non-structure is by side bending. If the curve side bending below 25 degrees, then this is non-structure, and you don't need to fuse it. If it's above 25 degrees, this is structure, and you need to fuse it. And that answers the problem of one curve or two curves. It's not that simple, but just leave it at that stage. Let me go very quickly through Lenke classification, because although divided into 6 types, it's so simple. The most common curve is the right thoracic curve. So that would be Lenke 1. And we are in the thoracic area, so we talk about 2 thoracic curve, right thoracic and high left thoracic, type 2. And then we're talking about right thoracic curve and there's left lumbar curve, type 3. And what about the triple curve, like the case I showed earlier, high thoracic, mid thoracic, lumbar curve, type 4. Now we leave thoracic and go to lumbar. Lumbar curve only, type 5. Lumbar curve and secondary thoracic curve, type 6. So simple if you just think this way. You start with the most common curve, right thoracic curve. You are still in thoracic, type 2. Thoracic and lumbar, type 3. Triple curve, type 4. Lumbar only, type 5. Lumbar and thoracic, type 6. This is talking about modification, modifier to add onto decision making. You don't need to waste your time. Let us go and have some fun by looking at some cases. This patient, still, all that's not worth it. Okay, this patient 1C, right thoracic curve, left lumbar curve. The main curve is the right thoracic, and look here at the side bending. The lumbar curve corrects to 9 degrees or 10 degrees. Right thoracic is the main curve. So this is type 1. C because the lumbar curve, we don't have to talk about that. But it's type 1, and the lumbar curve is flexible. So you're going to fuse the thoracic curve. And this is the outcome. You fuse the thoracic curve, you can see the lumbar curve corrected, the patient shoulder balanced, trunk balanced, hump disappeared. This is different case. Right thoracic, left lumbar significant, side bending is 23 degrees. Can be 25, could be 27. You shake your hand, you make it 21. So really when you come around 25, there's nothing written in stone. It's not just 25 means 25. It's general appearance of the patient important. Patient tilting to the left. Patient has a high, sorry, don't have it here. Patient has a high lumbar hump. Then in this case, if I follow the book, I do only right thoracic. But in reality, side bending for lumbar is questionable. I will do the lumbar, and you end up by a very happy patient because I did thoracic, I did lumbar, shoulder leveled, good kyphosis, good lordosis, very important, the hump disappeared, and the truncal balance, the head over the pelvis. So final point to cover, where to start and where to finish. So we decided we're going to do the structure curve with some modification later. If you get into scoliosis, we'll teach you about it. And we show the results when you do this. The non-structure curve will correct by itself. That's good. Now we're going to do, last thing is where to start, where to finish. Very quickly, the shoulder level will make you decide where to start. And the aim is to have level shoulder. See the high shoulder here? We need to have level shoulder. High shoulder, lower shoulder here, we need to have level shoulder, and so on. So we decide T4, T3, T2, T5 according to the shoulder. And that decision making where to start to control the shoulder level. Okay, where to end distally controls the coronal balance. You can end distally wrongly and the patient will be going to one side. And for this case, we design the lower end points at the end of the curve. We don't go beyond the end of the curve. Another case, right thoracic, left lumbar. Lumbar is very flexible. We're going to thoracic only. We have a balanced patient because we ended at the end of the curve, T12. You made a decision to do right thoracic, left lumbar fusion. So you end at the vertebra, which is very flexible. 3 flexible goes this way, on side bending. So I go to 3 instead of 4. End of the curve 4, but I will go to 3 because more to save out of fusion for the lumbar spine is better. And yes, the patient did very well, although she has significant curve, but side bending, you can see the 3 is free. We end at 3, truncal balance, good sacrificial lordosis, shoulder leveled, head center of the pelvis, and the hump disappeared. We use pedicle screws all the time, and there's a map to follow where you put the pedicle screws for thoracic spine. Technique of insertion, when you come to do fellowship with me, I'll teach you that. So we covered really everything except how can you create kyphosis and lordosis and how you eliminate the rib hump. Kyphosis and lordosis is the function of the bending the rod. You get big size rod, stiff rod, you bend it in the kyphosis you want, and you end up by proper alignment. And that's the function of the bending the rod. This is a technique by itself, to bend the rod to create the proper kyphosis and lordosis. For the rotation, the old days we do thoracolplasty, we don't do it anymore. We do vertebral rotation. And I'll show you the vertebral rotation very quickly in a second. Oh, the video. Okay, I guess the video doesn't like to come with me. No. Video. Very quickly. Oh. Thank you. So we put the structure here over the screws. The rod's in place, but by doing this, I'm controlling the vertebra completely. The 2 screws in the vertebral body, these rotators are connected to one screw linked here. So that structure for one vertebra is completely under my control. The vertebra screws in the vertebra, the 2 bars or 2 towers connected horizontally, so that none of the screws will cut through, none of the screws will go to the spine or go out in the aorta, it's controlled. And you take that and you move the vertebra any you want. We remember first slide, we showed you the rotation of the spine and creating the hump. We do rotate the spine, bring it back. So this right thoracic curve, my assistant pushing on the hump, and we are pushing the rods, the structure this way to rotate the vertebra back this way, then we tighten everything. Okay, go back again, I'm sorry. I almost done, I have 1 more minute. So the final thing is how to balance the spine. And as you remember, I said I stop at 3, but what I wanted to do at 3, to bring 3 parallel to the pelvis, 2 parallel to the pelvis, 1 parallel to the pelvis, and as a result, you have this picture. We stop at 3, but with my different technique I do here, I make those parallel to the pelvis, and you have a straight column of it, so the patient completely balanced. Last case to show you, another patient, we did right thoracic curve, and you can see before surgery, after surgery, for bending, there is no hump because we did the rotation. We didn't do thoracoplasty anymore. You take the vertebra one by one, you rotate them, and you have this correction. Patient for the hospital, maximum 5 days, and in 2 months, I let them do all the sports they want. No limitation whatsoever. Last patient to show you for one reason. This patient was gymnasts and came to me and said, I want to continue to be gymnasts. And I said, okay, we'll do that. And as a result, I was fulfilled my promise. So 5 months later, she did word thank you with her body movement. And you can see her body movement, very flexible, even the back arching. She did that. And she put word thank you for me. And with that, I'd like to tell you that thank you very much. I would like to invite you. I'd like to invite you to SRS meeting, Scoliosis Research Society. We go to nice places. We are going to be in Prague in September, and we're going to be in Washington, D.C. in July. Thank you very much.